we want to finish the fetal anomaly series course now, because we are still on anterior abdominal and GIT. So maybe for the sake of time, let me go through the part that we haven't covered on anterior abdominal, but I think we've done most of the talk on anterior, but there are still some areas which need attention. So this is exactly what I'm going to be doing now. But to just recap, just in case there are some amongst us who were not around or who didn't attend for one reason or another, let me just use this slide to recap the anterior abdominal wall defects. I'm sorry, my internet is not very stable here, so I'm just hoping we will succeed in what we are trying to do. Let me use my second device to see if indeed my screen is coming to you, because right now I can't even tell. Okay. Right. So yeah, there is a screen there. I think on your screens you can see that slide. Sorry, I'm just trying to activate another device so that I'm sure I'm always with you there. Right. I'm going to disable my video, try and improve things here. I'm not happy with the quality of my image. Right, so I've disabled my video. Okay, so basically this is the summary of the anterior abdominal wall defects that one needs to know. You can see on the left is exomphalos. Exomphalos is easy. You just know that the bowels are covered by a membrane, as you can see there. So it's covered by a membrane. So that's exomphalos. We said exomphalos, in about half of the cases, there's an association with either trisomy 18 or 13. So these babies invariably have to be offered karyotyping. The couple rather decline, but you have to offer and you have to document that karyotyping has been offered, because in half of the cases, you are doing trisomy 13 and 18. More than a third of them will have other associated defects. Normally, they could have scoliosis. They could have cardiac defects. So always be aware that exomphalos is associated with other things, both chromosome and the other defects. So the moment you pick exomphalos, it is now imperative that a detailed anomalies can be done to check all the other organs. Gastroschisis, the walls are just all outside. There is no membrane covering. They are floating. Cardiac defects have to be ruled out. These babies may have fetal growth restriction. And the association with chromosome abnormality is very low. So in isolated cases, we do not routinely offer them karyotype. But of course, you have to tell them that, look, there is a very low association with the abnormal chromosomes. If they're an anxious couple, they may choose to have amnio, but if they are not, they may choose not to have it. And we will not take beef with it, because we know that the association is very low. That's gastroschisis. And between the two of them, from us on the prenatal side, gastroschisis is a better prognosis outcome than exomphalos because of its poor association with chromosome abnormality. If we take them all from 12 weeks, let's say we take all the gastroschisis and exomphalos as early as 12 weeks and we follow them up, we're going to probably have more life-born babies who are healthier with gastroschisis than exomphalos if we take the same number. Body stock anomaly. I think let's get this one clear. In body stalk anomaly, we have a situation whereby the amnion membrane ruptures. I think by now we are all aware from our 11 to 13-week lectures that the amnion and the chorion are actually separate until 15 weeks. They are not totally fused until 15 weeks. So for some babies or some pregnancies, unfortunately, the amnion ruptures and a certain part of the baby goes through that rupture on the amnion. So that we may have a situation whereby the liver is not directly attached to the placenta with a lot of deformity. They invariably have anterior abdominal defect. It's more like the amniotic bone sequence syndrome on the other side of severity. So you have these organs which are ruggedly attached to the placenta, as you can see there. The liver is directly feeding on the placenta. The umbilical cord may not even be seen or may be very short for these babies. They have severe deformities, especially the spine. They have severely deformed. It is lethal body stalk anomaly. So please take note of this. And these babies are somehow fixed or they are arrested of somehow. Then we have the pentalogy of Cantrell. Pentalogy of Cantrell, how do you distinguish it from these ones? In pentalogy of Cantrell, we also have the heart, ectopis cardia. So the defect starts a little bit higher. It goes all the way to the sternum, so that the heart is also outside. This is how we distinguish from the others. So in other words, we're going to have a high exomphalos and ectopis cardia and a heart which is outside the chest. Cloacal extrophy, we're going to have a low exomphalos and bladder extrophy. And we could have a bifid penis for boys or a vagina which is really abnormally parted. But we have bladder extrophy as well there. A bladder extrophy is part of on its own, is part of the anterior abdominal defect, so it's not there. So in other words, you have about 6 of them, including bladder extrophy, whereby the bladder is not closed, its mucosa is outside. So these are the anterior abdominal wall defects, and you need to be well versed with them. I think we summarize them well in our slides. Those who are not around, you are more than welcome to go and watch on our channel, the Fetal Medicine Foundation Zimbabwe YouTube channel. I think those presentations are on the channel. So I'm sorry, my internet is not good, so I'm going to carry on from where I left. But those who want to watch, just go on the YouTube channel and no, this is not my presentation. Okay, there we are. So this is my presentation. Because I know I'd covered all this. Esophageal, yeah, all this was covered. No. Oh la la. Let me see, because this is not the presentation. As you can see, I was still working on it. Sorry about this. Maybe what we can do is, I think let me just carry on for the sake of time, because my computer is underperforming. So I'm just going to carry on with this presentation. It's not the well-edited version, but I'm going to carry on. But I know we had covered all the way up to the anterior abdominal defects, and we also had done esophageal atresia and duodenal atresia, but we had not covered abdominal cysts. So I will carry on with the abdominal cysts. So abdominal cysts, I'm not sure if what I'm not going to put on slideshow here because my computer is misbehaving. I think I need to be able to see and choose where to go easily. So I'm just going to leave it a little bit on the bigger side that I put on slideshow. Right. So abdominal cysts, they are as common as 1 in 5,000 births. Obviously, prenatally, they may be higher than this because some of the babies with these cysts may not be born, may be miscarried, and so forth. So the ultrasound scan diagnosis is very easy. Normally, you may see an over-dissection of the rectum and sigmoid colon in the 3rd trimester and a normal amount of amniotic fluid. And occasionally, intraluminal calcification, which is meconium, can be visualized. Sorry, this is anorectal atresia. Anorectal atresia. So let's do it, then we go back to. So the association of chromosome abnormalities occurs in about 3 to 4% of the cases. So in this case, we offer the woman the option of amniocentesis. Then the other defects, they are mainly urological malformation. Then we have vertebral anomalies and CNS defects, which may be found in about 70% of the cases. So the moment you pick you suspect that you are having a sigmoid colon or an over-descended rectum, checking of all the organs is now imperative because of the association with other defects. Sometimes you may have the non-genetic syndrome like the Vactel. The Vactel associations, they are normally this is sporadic. We have the vertebra, the ventricular septal defect, the atresia and tracheoesophageal fistula, and renal anomalies and radial dysplasia and single umbilical artery. This is what we see with Vactel. So always be aware of this word Vactel because you're going to meet it more often as you do more in fetal medicine. That Vactel means we're talking of vertebral and ventricular septal defects, atresia, tracheoesophageal fistula, renal anomalies, and radial dysplasia. Then we can also have an association with caudal regression syndrome, with this sporadic sacral agenesis or hypoplasia and hypoplastic vertebral bodies or atresia. How do you suspect caudal regression syndrome? You of the spine. This is why it is important to examine the spine both in sagittal and also in coronal plane. This will allow you to assess the ossification of the bones. Because you are going to lose that ossification, you are going to lose the classical rail pattern that we see, because it will be more hypoechoic. Then we also have the OEIS syndrome or complex, which is sporadic again, where there's oxymvalus or umvalocele, then extrophy of the cloaca, which is cloaca extrophy, and we have an imperforate anus and some spinal defects. So these non-genetic syndromes, this is why whenever you see multiple defects, you need to use the syndromic approach. As we discussed when we were doing MIMS, I think you guys still remember that when we were doing Mendelian inheritance in men, how to use the syndromic approach to try and come up with a specific syndrome responsible for fetal malformation. We cannot overemphasize, but the detailed ultrasound scan examination is required. And normally, for the defects of anorectal atresia, the follow-up is normally standard, and delivery should be in a hospital in neonatal intensive care and pediatric surgery, and the time is 38 weeks. 38 weeks is very key in fetal medicine because this is where we want to deliver most effects. Mode of delivery is not influenced by this defect, so there's no need to change the delivery plan here. It's not affected. Then the prognosis, in isolated cases, the overall diagnosis is good, or survival is good. In cases presenting with multiple malformation, the prognosis is poor. There is no increased recurrence in cases of sporadic cases, but when it is part of trisomies, the recurrence risk is 1%. So the other rule of thumb that you need to remember is that whenever the trisomy is associated, or whenever there is trisomy, the couple need to know that the risk of recurrence is 1%. This is why they need to come for early screening. If you read the books, I think old books, right, before NIPT, women who have had a previous baby trisomy, they would not be offered the combined test, but they would go straight for amniocentesis. But in the era of NIPT, we should know that they have an option to do NIPT instead of going for the needle test because of that 1% risk of recurrence. So we should remember that. Let me just go back to the cysts, just summarize the cysts a little bit, because there are a number of cysts we can see. Then abdominal cysts. So the cysts may vary, but they could be renal in origin, or it could be just bowel. But we could also have cystic structures arising from the biliary tree. We can also have an ovarian cyst and or mesenteric cyst, or the uterus may, in very rare circumstances, may become cystic due to some form of hematocorpus in the uterus, but this is not common. The correct diagnosis, normally it's a very tricky situation to diagnose the cyst and say what it is. But what helps in terms of diagnosis is to know the position of the cyst. And also remember anatomy. If you know your anatomy, you know what is where in the human body. So your knowledge of anatomy will help you to try and approximate the likely cause of the cyst. So anatomy is very important, to know anatomy, to know what is where. For example, if you see a cyst on the liver, there's no way you are going to say it's more likely an ovarian cyst. It's highly likely to be biliary tract cyst than an ovarian cyst if it is in the position of the liver. But the problem will come if you don't know where the liver is. That means you may potentially label a cyst which is ovarian in origin, like a liver. You may call it something which is in the pelvis, you call it ductal cyst. So knowledge of anatomy is very important. You should be able to localize. So I'm going to go through some of the common cysts that we may come across as you scan. We have a ductal cyst, which is normally a cystic dilatation of the common biliary tract, and it's found on the upper right side of the fetal abdomen, where there is the liver. Like I told you that you should know where the liver is. There is normally communication between the bile duct and the cyst. That is how you are able to suspect that this is likely to be a colorectal cyst. Then absence of polyhydramnios or peristalsis may help to differentiate this condition from the bowel disorders. So if you don't see polyhydramnios and you check that cyst, there is no peristalsis, it's highly likely that it's a colorectal cyst than a bowel obstruction. So postnatally, it is important that the diagnosis is confirmed early and the cyst is removed to avoid the development of biliary cirrhosis or portal hypertension or cochlear formation and adenocarcinoma. The operative mortality is about 10% for the colorectal cyst. So it's a serious condition. Then we have the other cysts, the mesenteric cysts. So for the mesenteric endometrial cysts, they are normally as a result of obstructed lymphatic drainage. The fluid may be serous or chylous or hemorrhagic. The diagnosis is suggested by the finding of a multiseptate or unilocular cysts, which are usually on the midline. And the cystic lesions, they vary in size. A solid appearance may be secondary to hemorrhage, so be aware of that. Antenatal aspiration may be considered in cases of massive cysts resulting in thoracic compression, where you feel that they may impair lung development. Postnatal management is conservative, and surgery is reserved for cases with symptoms of bowel obstruction or acute abdominal pain following torsion or hemorrhage into a cyst. Complete excision of the cyst may not be possible because of the proximity of major blood vessels. In up to 20% of the cases, there's recurrence after surgery. Malignant changes in mesenteric cysts has been described. So that's mesenteric or omental cysts, normally on the midline. Then we have the hepatic cysts. These are normally located on the right lobe of the liver. They are very rare and result from obstruction of the hepatic biliary system. They appear as unilocular or intrahepatic cysts, and they're usually asymptomatic, although rarely may show complications such as infection or hemorrhage. Hepatic cysts are found in 30% of the cases of adult polycystic kidney disease. So intestinal duplication cysts. These are very rare, but may be located along the entire GIT. They appear as tubular or cystic structures of variable size. They may be isolated or associated with gastrointestinal malformations. Thickness of the muscular wall of the cyst and presence of peristalsis may facilitate the diagnosis. Postnatally, surgical removal is carried out. So these are intestinal duplication cysts. So we have the choledochal cysts, we have mesenteric or omental cysts, we have hepatic cysts, and we have intestinal duplication cysts. Very important to remember this. So I've already gone through this. Let me, I know I did esophageal atresia last time, but maybe let me just quickly recap duodenal atresia, but just in case for some who are not there, it's a very common condition. 1 in 5,000 is the prevalence. The diagnosis, in most cases, not the double bubble, but people will see polyhydramnios. I mean, for the case that we end up diagnosing, people are referred to us for polyhydramnios, but if a clever sonographer had scanned them, they will mention that they saw a double bubble. So this is how it looks. So you are going to see a double bubble like this, right? So that's a double bubble there. What causes the double bubble? What causes the double bubble is that we have the stomach. Remember, after the stomach, we have the pylorus. Then after the pylorus, we have the first part of the duodenum. So the atresia normally affect the second part of the duodenum. I think you're aware that the duodenum has 3 parts. If my gross anatomy is still okay, but the duodenum has 3 parts. So the atresia is normally found between the first and the second part of the duodenum. Okay, within the second part of the duodenum. So because fluid is accumulating in the stomach, but it's not being able to pass through the second part of the duodenum. So what you are seeing here is the stomach and the pylorus and the second part of the duodenum. That's what we are seeing there. So this is what is responsible for the double bubble. We could have total duodenal atresia, but we could also have duodenal stenosis. I think the differentiation doesn't matter on our side of fetal medicine. It's important on the side of the ped surgeon, the pediatric surgeon. But on our part, we shouldn't miss this kind of a case. The problem with duodenal atresia is that you can potentially miss it during the 20-week scan because the double bubble may not appear. I don't know what is happening now. The double bubble sign may not appear before 24 weeks. And the polyhydramnios secondary to duodenal atresia again may appear late. So there is potential to miss. Right, I think I'm still with you there. So there's potential that you could miss duodenal atresia. Very easy to diagnose because we diagnose it at the level of the abdomen, where we do the abdominal circumference. Some may wonder and say, why is it important to pick duodenal atresia? Because if you don't pick them up, they will be fed after birth and they will vomit in their lungs, and that will be the end of their story. Picking them up will mean that we are going to recommend that NG should be put, that they be delivered in a center with pediatric surgery. Let me repeat what I said the other week. Verenga group of hospital and the United Blawayo Hospital, they do not have pediatric surgical units. I'm not sure if you yes, but I thought Mpilo is one, yes. So these babies should be delivered at Mpilo and Salimugabe if we are to give them a chance. Because if we deliver them at the wrong hospital, they are going to take 24 to 48 hours to be transferred to their right hospital where there are people who can operate them, or they are going to be mismanaged and be fed by somebody who is not aware of what is happening, and even actually told the mother to go on and feed. So they need to be delivered in a hospital where there is a team with experience to look after these babies who know what to do. Otherwise, it is a disaster for duodenal atresia being delivered outside a pediatric surgical unit that knows, that is experienced in managing them. So please be aware of this. We are the change agents. You have to inform people. Otherwise, there are people who are overzealous who think their hospital should deliver everyone. Not really. If your hospital is not equipped with certain service, don't deliver them at your hospital. Otherwise, we are leading them to their eventual death, which is unnecessary in duodenal atresia. So duodenal atresia is associated with trisomy 21 or other triploids in a third of the cases. So the moment we pick duodenal atresia, karyotype is mandatory, is required. I'll just recapping duodenal atresia. Survival is very good, up to 95%. Then we have esophageal atresia. I'm certain that I did something the other week on this, but to just recap. So you can see that these are the large classification of the esophageal atresia. We have type 1, type 2, type 3, type 4. So which type are we able to pick on ultrasound? Potentially able to pick. On ultrasound, these will be the easy types to pick. Number 1 and number 2. Number 3 and 4, unfortunately, there is a communication with the upper oropharyngeal part there. So the stomach will show. It may be small, but the stomach will show. So as long as the stomach will show, it is difficult to say this esophageal atresia. So it is only 11% of the tracheoesophageal atresias that we are going to pick because of the tracheoesophageal fistulas that do also okay. So this is the challenge of esophageal atresia, that most cases unfortunately will be missed. About 90% of them are missed prenatally. So do not punish yourself if you miss them. It's not just in Zimbabwe, but globally they are missed because these ones will show you the stomach. Nobody will know that there are these fistulas inside. All right. So that's esophageal atresia. So as far as esophageal atresia, you can see, you don't see the stomach here. This is one of our other cases. The stomach was collapsed here, totally collapsed stomach, and here there's no stomach at all. Right. So yeah, I'll skip this, just a recap, because I believe we covered it. We covered esophageal atresia for the sake of time. Let me go to hepatic calcifications. So these are as common as 1 in 2,000 fetuses at 20 weeks gestation. Ultrasound diagnosis, you need presence of solitary or multiple echogenic foci, 1 to 2 millimeter in diameter within the substance of the liver or in the capsule. The associated abnormality, the incidence of chromosome abnormalities and genetic syndromes is not increased, and the parenchyma calcification may be due to intrauterine infection. So how do you wake them up? We need a detailed ultrasound scan examination, and you need to do a torch test for fetal infections. The follow-up in isolated cases, follow-up should be standard, and delivery standard obstetric care and deliveries should be given, and the prognosis is good, and no increased risk of recurrence. Some of you may wonder why we are taking you through all this to say, how do you follow up? How do you deliver? How do you do prognosis and recurrence? When babies are referred to us with defects, the obstetric teams expect us to give them advice all the way up to how the baby should be delivered, including counseling on prognosis and the issues of recurrence. That is our work as fetal medicine. Our work is not just to diagnose them. Our work is to manage them not only in the current pregnancy, but to also begin to manage the subsequent pregnancy. So this is why this information is important to you, to know that the condition that I'm dealing with, does it have recurrence? In the next pregnancy, what is it that the doctor who is managing this patient should do? Or do they need to come and be seen by us at 11 to 12 weeks? Or do they need to come and be seen by us preconceptionally? This is why you need to know all this other detail, which is following up to say, how do you manage them? What is the follow-up? What is the program? How should they be delivered? Because in the hands of lack of this knowledge, most babies with defects will actually be offered unnecessary cesareans. I know this. People may ask and say, how do you know? I know because when I was an obstetrician, I remember many cases would be sectioned because they have a fetal defect. So in most fetal defects, cesareans are necessary. Hirschsprung's disease, 1 in 3,000 is the prevalence. The condition is characterized by congenital absence of intramural parasympathetic nerve ganglia in a segment of the colon. The aganglionic segment is unable to transmit a peristaltic wave, and therefore meconium accumulates and causes dilatation of the lumen of the bowel. The ultrasound appearance is similar to that of anorectal atresia when the affected segment is colon or rectum. Babies present with polyabdominals and dilation of the loops are present in cases of small bowel involvement. It is always difficult to distinguish from things like ileojejunar atresia. The chromosome abnormalities, mainly trisomy 21, are found in about 5% of the cases. A detailed ultrasound scanner examination is required, and karyotype for DNA to rule out trisomy 21 is required as well. The follow-up every 2 to 3 weeks to monitor the evolution of the condition and to assess amniotic fluid, and also amniotic drainage may be necessary if there is polyabdominal and cervical shortening. Delivery place, hospital with intensive care, and facilities for pediatric surgery. So note this, that a number of fetal defects have to be delivered in the right hospital, where we know that surgery is required. Then timing again, 38 weeks, method induction of aiming for vaginal delivery. There is no need for cesarean here unless if there's an obstetric indication. Postnatal surgery is aimed at removing the affected segment, and this may be two-stage procedure with temporal colostomy. Neonatal mortality is approximately 20%, no increased risk of recurrence, and part of trisomy 21 is 1%. Like I was telling you that whenever there's an underlying trisomy, the recurrence risk is 1%. Again, why do you need to know this information on prognosis? Because this is how far our counseling goes when we see pregnant women with fetal defects. Nobody is better positioned to counsel them than us, who will just scan them. Of course, we know a more detailed scan is going to be done by the operating doctor or pediatric surgeons, but we should have basic knowledge of standard therapy that is offered, that is recognized for these women. So, liver tumors, they occur in 1 in 100,000. The most common are hemangioma, mesenchymal hematomas, hepatoblastomas. They can be cystic, or echogenic or mixed solid and cystic, which is complex in ultrasound. They may just present with hepatomegaly. The hemangiomas and hepatoblastomas may be associated with evidence of high output heart failure, hydrops, and polyhydramnios. Color Doppler studies may be helpful in distinguishing hemangioma from the other tumors. The associated chromosome abnormalities, there is no increased risk with the chromosome abnormalities, but hepatoblastoma can be associated with Beckwith-Wiedemann syndrome with evidence of organomegaly and macroglossia. You remember we did Beckwith-Wiedemann syndrome when we were doing overgrowth syndromes. So Beckwith-Wiedemann syndrome. So you can go to the overgrowth syndrome lecture to know more about Beckwith-Wiedemann syndrome. Detailed ultrasound scan examination, including echocardiography, is needed, and Doppler ultrasound scan to define vascular anatomy of the liver, fetal MRI to define the extent of the tumor and its relation with the intrahepatic structures and adjacent organs. The follow-up every 2 to 3 weeks, monitor the size of the tumor and development of heart failure and polyhydramnios. In the case of large hemangiomas associated with high output heart failure, maternal administration of steroids may arrest the growth of the tumor. So remember this, that steroids may be used in this kind of situation. Delivery, again, hospital with intensive care and pediatric surgery, timing around 38 weeks. For large vascular tumors, cesarean section may be considered to avoid rupture during delivery, natural delivery. The prognosis for hemangiomas, survival is about 80% after treatment with steroids. However, if there is associated with atriovenous shunting or fistulas, congenital heart failure and hydrops may complicate the situation for these babies, which may result in the IUFD or neonatal death. After infancy, the tumors regress spontaneously. Mesenchymal amatomas, surgical resection with survival in about 70%, while for the hepatoblastoma, surgical resection with 6% survival. Prior to resection, several cycles of chemotherapy may be required to shrink the tumor. In general, there is no increased recurrence for these tumors. In hepatoblastomas, which are associated with Beckwith-Wiedemann syndrome, which is autosomal dominant, by the way, and also those associated with familial adenomatous polyposis, which is also autosomal dominant condition, the risk is increased. Meconium peritonitis is occurs in about 1 in 3,000. I think I'm about to finish. This is the presence of intra-abdominal high-pay echogenic areas, which are peritoneal calcifications, result from intrahepatic perforation of the bowel, which leads to a local sterile chemical peritonitis. We'll see additionally dilated loops of bowel, ascites, and the Meconium pseudocyst. Associated abnormalities, the incidence of chromosome abnormalities and genetic syndrome is not increased, but the risk of cystic fibrosis is 75%. We know amongst our Black population, cystic fibrosis is very rare, but remember, our population got heterogeneous, it's getting heterogeneous, especially in big cities like Harare. You will come across Caucasians and other races where the incidence of cystic fibrosis is high. So you should be clever, fetal medicine patient, and know that this condition, that's okay. Detailed ultrasound scan examination is required, and amniocentesis is done to try and diagnose cystic fibrosis. Especially if both parents are carriers. Torch test for fetal infection is also recommended. Every 4 weeks to monitor evolution of the condition, fetal growth is the follow-up plan. Again, delivery, intensive care and pediatric surgery unit. 38 weeks is the time, and induction of labor is the way to go if there's no obstetric contraindication. In case of simple peritonitis, the outcome is good and surgical intervention is not necessary. In case of complex, which is associated with bowel dilatation, the ascites, the prognosis is poor, and neonatal mortality is greater than 50%. In isolated, there is no increased recurrence risk. I still have more slides to go. It's now 5 to 9. I'm thinking I should stop. Next week, I should be able to finish what remains of this topic. So I'm going to stop here. Then next week, we'll finish what remains of this topic. And yeah, thank you so much. And enjoy your weekend. Maybe I'll leave the room for questions. If there are any burning questions on what I've just presented. Otherwise, some questions may be directed on the group, on the Zoom fetal group, if there are any questions on the talk. Okay, so if there are no questions, I will end the meeting. Thank you so much and enjoy your weekend. Bye-bye.
Thank you, Doc.
Sure.